Hello and welcome everyone to our tonight's event. It's 8 p.m. UK time, so it is time to start our event, of course. And I'm very happy that we are here once more, and we do have another interesting topic to discuss. And of course, as you can see, we do have a very special guest with us as well. As you can see, this is Professor Suks Minhas. I'm very happy and proud that you have been able to actually join us tonight. And how are you feeling today?
Who me? Very good.
Yes,
Thank
of
you. Sorry,
course.
I thought you were talking generally. No, I'm very good. Thank you very much
Thank
indeed.
you so much for joining us tonight, for sure, and of course for presenting this particular topic. Because today we are starting our topics on male reproduction, and I think everyone can agree that male reproductions, those things are still not discussed enough. So thank you so much for presenting this topic on male sexual dysfunction, and of course, as you know, we will start with Professor Minha's presentation, and afterwards, as always, it will be time for your questions as well. So if you have anything that you would like to ask, you will be able to do so during the presentation or afterwards, and I'm sure Professor Minhas will be happy to answer all of your questions. And let me just mention that Professor Minhas is the consultant urologist and andrologist at Imperial College in London. So he has vast experience and knowledge on the topic that he is presenting tonight. So yes, that will be it from me. Okay, remember it's being recorded. So if you have, I hope not, but if you have any issues or with the sound or anything like that, don't worry, you will be able to watch this for sure. And that will be it from me at this point. So let's start with the presentation, okay?
Thank you.
Yep, perfect. Go ahead.
Thanks very much indeed, Karen. It's very kind of you for that introduction. Hello, everybody. Good evening. It's 8 o'clock in London. I've just got in from work from a long day, looking at many patients with fertility problems and also with male sexual dysfunction. So I'm a urologist or andrologist. I work at Imperial College in London, and I'm delighted to be here. So let me just start the talk and just talk to you a little bit about male sexual dysfunction, what that means and what that covers. So from a patient perspective, male sexual dysfunction is a problem that can happen in any phase of the sexual cycle response. And there are a variety of kind of sexual dysfunctions. These include both erection problems or commonly what we term as impotence, although we commonly now call it erectile dysfunction. And there's also ejaculation problems as well. So obviously for couples who are trying very much to have children, what can happen, of course, is that sometimes sex can become a little bit regimented. Sometimes you can get problems in getting erections. And also in some cases, you can also get difficulty maintaining erection. Furthermore, we also get issues surrounding ejaculation as well. So sometimes you get men who can't ejaculate. So I think it's useful to go through kind of what sexual dysfunction is, what causes it, and there are, of course, other kind of pathological problems or problems you can get which can cause these erectile problems as well. So in terms of kind of how common is it? Well, it's actually very common indeed. And I'm just going to show you the next slide here. There are different phases to the kind of, sorry, I've just skipped a slide. There are different phases to the normal sexual male response. Certainly the sexual stimulation generally causes the penis to become tumescent or more erect. What also happens as well is that you get arousal, then you tend to have penetrative sex or some form of sexual function, and then orgasm, and then ejaculation or producing ejaculation fluid occurs. And after that, what happens is that generally speaking, the penis goes down and becomes detumescent, as it's commonly called. What we need to be aware is very common, and there's this kind of misconception that it's not a common problem and patients get embarrassed about this. And I can tell you that overall the worldwide prevalence of erection problems is very high. About 152 million men in 1995, projected to 322 million in 2025. So it's a very common problem. There are quite a lot of causes of erectile dysfunction. Remember, erectile dysfunction is the inability to maintain or sustain an erection adequate for intercourse. And so you can see that there can be common causes such as diabetes. What's interesting is about 70% of men who are diabetic may have some form of erectile problem. We term vascular causes. Vascular causes are men who have problems in blood flow. The penis is, in fact, as we'll see, just like a muscle, and the same things that affect the heart can affect the penis as well. There can be endocrine problems or problems in terms of hormonal function as well. In other words, it can be testosterone issues and other problems that can cause erection problems. It can be neurological, so some men who've had spinal cord injury, surgery that disrupts the nerves to the penis can also get erectile dysfunction. And certainly you'll be aware probably that some men who've had surgery, for example, to the pelvis, in other words, surgery to organs in the pelvis, you can damage nerves. And sometimes medications as well can also affect the erections as well. So it's important when we talk to patients, we ask them about all of these. So if we move on, we can see that if we look at kind of the risk of erectile dysfunction as you get older increases. So as you can see here, that in fact about 50% roughly of men between 40 and 70 years of age will have some degree of erection problem. It may be minimal or to complete erectile dysfunction. So it's very, very common. And I think it's important to highlight that to patients so they don't feel alone in the problem. There are, of course, many drugs on the market for erection problems, and these are some of them. Many of you have heard of Viagra, perhaps you've heard of Cialis, but of course you can now buy Viagra across the counter, or sildenafil as it's commonly called. So the causes, as we already mentioned, are here. You can see that smoking, but also we mustn't forget the psychological issues as well. So depression, for example, patients may be down, they may also have erection or problems in terms of getting an erection as well. But we've already gone through this list here. So it's important that when men present with erectile dysfunction, there are physical problems which need to be assessed, but there are also psychological problems as well. And particularly in fertility, that's important as well from a hormone perspective as well. So again, I just want to put this slide up again because it just highlights how common the problem is, and that's very important. Okay, so 50% of men at that age, and that's quite a profound problem. Why do we get it? Well, look, this is a anatomy drawing, okay, of the kind of penis state here, basically. And what you can see here is you can see that this is a bladder, this is the prostate here, and these are the nerves that supply the penis. And you can see that in some men who've had surgery, you can damage the nerves and the blood supply to the penis, because when you remove some of these organs for various diseases, that's what can happen. This just shows you how the prevalence, or in other words, there is an increase in the numbers of men as they get older who have erectile dysfunction. And you can kind of see that it actually reaches very high levels as men reach 60 and above. So it is very, very common. Why do we get erections? I mean, that's important as well, because obviously there's kind of stimulation to the brain, which can be visual, various other factors, imagination, tactile responses, all result in an increase in blood flow to the penis. And you get these neural or these kind of nerve impulses, which are from the brain, which is mainly in the center of the brain, which go down to spinal cord, which then go down to what we term as the lumbosacral area, which is the lower spinal cord, which then provides nerve input to the penis. And this then causes erection. There are some nerves that cause erection, which are called the parasympathetic system. Some nerves that actually cause erection to go down, called the sympathetic control. And these act in a kind of a balance in order to maintain an erection. When men ejaculate, there are two phases. So when you get stimulated, when you have an erection, then you get contraction of the muscles of the sperm tubes or the epididymis, the vas deferens, which propels sperm into the urethra, which is where the water pipe where you pass urine from. And from there you get contractions of the muscle, which then expels the ejaculate, and that's called the expulsion phase. So that's when you get fluid that is then comes out the penis. And they're very complex methods, okay? But overall, there are other problems can affect ejaculation. So you can get, for example, painful ejaculation, which can be due to inflammation of the organs or the prostate. Sometimes stones, sometimes problems can cause blockages of the ejaculate, which can then cause problems in terms of ejaculation factor fertility issues as well. Sometimes men ejaculate too early, and what happens is that during ejaculation they get something called premature ejaculation, when they can ejaculate even before they have sexual activity with their partner, and furthermore they can ejaculate too early that their partner's not satisfied sexually. We generally think that that occurs usually if the time to ejaculation is less than a minute. And therefore, you've got to see that there's also a wide response in terms of when men ejaculate in terms of time, but the average seems to be about 5 minutes. Premature ejaculation is one such sexual dysfunction, to call it, and it is a big problem. And in fact, many men tend to feel that this can be a significant problem. Often what happens is, particularly men who lose their erections, they tend to want to ejaculate earlier because they feel they're not going to maintain the erection, so they've got to ejaculate quickly. And this is really more of a psychological problem, a mechanism. And it's quite common. I mean, if you look at it, you can see that, almost a third of men at most ages, depending on, as you get older, will have problems in early ejaculation or premature ejaculation as well. And these are some of the studies around in Europe, and as you can see here, that it does vary surprisingly in terms of who gets it and how often they get it in different countries around the world, which I think is probably more social as well. And you can see here the different kind of prevalence rates, but that will be dependent upon who's reporting it, which country, and who's doing the study. And there's be lots of cultural and religious reasons for that as well. So we classify as well. Some men have had premature ejaculation for most of their life. That's called lifelong as well. Some men acquire it, and therefore when they get erection problems, they find it difficult to actually not ejaculate early because they're worried the erection will go down as well. But often the cause is psychological, which is very important to stress. So we tend to try and treat patients. Okay, so when men have early ejaculation or perceive it as a problem, remember the partner also needs to be there as well when we're talking to them, then very occasionally we then refer them on to treatments, and some of these treatments are psychological and behavioural therapy, which has a very positive action in terms of helping men with early ejaculation. You then get onto a very difficult area, and obviously one of the problems is that some men require medications because they can't actually maintain, even with psychological therapy, and increase the length of time of their early ejaculation. And sometimes men are prescribed drugs or antidepressants, and these are not antidepressants because they're depressed, but rather these drugs act by increasing the levels of chemicals, which is serotonin, which then actually has a damping effect on the reflex from the brain and the spinal cord in terms of the early ejaculation, so prolongs the early ejaculation. In fact, there is a drug called dupoxetine which can be used in this scenario, but of course you would need to be evaluated for that. So I think it's important to realize that it is very bothersome. There are various treatments for it, including behavioral therapy or psychotherapy. We sometimes use local anesthetics. We sometimes also obviously use these drugs such as dupoxetine, which is these SSRIs, which are short-acting, which act to increase serotonin levels. And this is just showing you the nerves that are actually dampened. In other words, the nerves that normally cause ejaculation are delayed in terms of their reflex by increasing the levels of serotonin. What is normal? Well, it's difficult to say. As I said, generally speaking, it's very variable. Patients or couples can have very pleasurable experiences, even if the ejaculation time is less than a minute. This is about dupoxetine, which is a drug we've just spoken about as well. These are various other medications that sometimes used, as I've already mentioned. Again, you need to see your doctor when you're going to be taking these types of medication, and it's important to obviously get assessed for that, and also to make sure that you are actually able to have these types of drug. So the other issue about sexual dysfunction, and we must remember the erectile dysfunction, is that we also must remember that it might be a sign of vascular disease, cardiac disease. Remember I talked to you earlier about the muscle of the penis being almost like a barometer of your general health. Now, interestingly, something called metabolic syndrome is related to low testosterone levels. And low testosterone levels can cause obesity. It can also affect fertility, interestingly, as well, because it can affect the hormone levels from the body. So why do we need testosterone? Testosterone is not only important for sort of body hair, secondary sexual characteristics, also to increase the blood count in the body, also increase muscle bulk, but it's also important for sexual function in terms of the erections as well. Now, the only thing that you need to be aware of is that men have got this misconception that if their testosterone is low, giving themselves testosterone will boost their fertility. That's not the case. In fact, if you give yourself testosterone and your sperm production is normal or even abnormal, you'll suppress it. It acts like a male contraceptive. So you should never give yourself testosterone if you want to have children. In fact, it should be prescribed by doctors. So what we see with men who have an increased weight is we often see this kind of waist girth, or this central adiposity, we call it, or an increased fat around the waist, which actually lowers testosterone, interestingly, which can have an effect on overall the erections, but also predispose to things called cardiovascular disease, such as insulin resistance, which causes a predisposition to diabetes as well. So this is why it's also important to not ignore erectile dysfunction and sexual dysfunction, because there may be other underlying diseases. Now, obviously, as one gets older, that increases in terms of its frequency. But in the younger guys in their 20s, generally speaking, it's often more psychological than physical, but you still need to exclude some of these things. And this just shows you about metabolic syndrome. So this risk of cardiovascular disease increases as men get older, and this is because the erectile dysfunction shares the same risk factors as cardiovascular disease. And this just shows you here that the relationship between low testosterone and this metabolic syndrome, which is this central adiposity, which I just mentioned, which increases the risk of cardiac disease. How do you get an erection? I just want to go back again, that many men come to clinic and often see me in clinic and say to me, well, how does it all work? Why am I getting erection problems? Again, this is to highlight, it's very complex, the blood supply and also a nerve supply to the penis. As you can see there, we already put this picture right at the beginning. There are different spinal pathways for this. So anything that can interrupt that can cause erection problems as well. If you look at the penis itself, just to kind of give you a quick lecture on the penis and the erections, the penis is essentially like a muscle tube, okay? And essentially that muscle tube is responsible for getting engorged. So the blood flow goes into the penis and it's a sponge work. So as you men get sexually stimulated, the nerves get stimulated, blood flow is stimulated. There are some muscle areas within the penis because your penis consists of two muscle bulks, and these dilate and essentially get filled and engorged with blood. And that's how you get an erection. Now, if you haven't got enough blood going into the penis, then of course that will cause the penis itself not to get rigid. And equally, that can have a secondary effect in terms of maintaining the erection. So blood flow is very important to the penis, and that can be affected, as we've already seen, by cardiovascular disease, in other words, furring of the arteries to the penis as well. And this just shows you in the flaccid state, the muscle tubes are non-dilated, but in the erect state, they full of blood, and you get the erections occurring. So this is, in fact, the muscle of the penis. This is one of the muscles, okay? And this just shows you diagrammatically drugs that cause, for example, erections such as Viagra and Cialis. They act by inhibiting enzymes. I don't want to go too much on that, but it's complex. But these drugs that you try and give patients sometimes to help erections after you've investigated them also have side effects around the body, and this is due to these enzymes that are in the cells around the rest of the muscles of the body. So sometimes men who you prescribe these drugs get problems such as flushing, headache, dizziness, and indigestion problems as well. And here are the side effects, but less than 5% of men stop the drugs because of these side effects, and these side effects are due to the enzyme that is inhibited around the body, which is called phosphodiesterase, by drugs like Viagra and Cialis. And again, there are certain drugs which have other effects. So, for example, visual effects as well. So, they can affect your eyes as well. There are a number of drugs and medications. These are some of them. Some of them are short-acting. Some of them are longer-acting. It depends on the patient's preference. Sildenafil citrate is available off the counter or OTC. And as you can see here, that is short-acting. And it's very quick to act, but you've got to remember that you've got to have an empty stomach and not have alcohol with it. Tadalafil, on the other hand, which is Cialis, is longer acting. It takes 2 hours before the onset of its action, but may stay in the body for quite a long time, in fact, 24 to 36 hours. So often people prefer this drug because it's a bit more spontaneous. But there are, of course, others such as vardenafil and avanafil as well. I wanted to mention this as well, that often men have prostate operations as well, and the prostate's important for sexual function, infertility, as we see, and you can obviously get problems there with erections and the loss of ejaculation. And also men often describe the penis as got smaller in these circumstances. This is important because it's important to remember that as men get older, you'll often have to do surgery to remove the prostate for prostate cancer, and it can have these effects as well. Sometimes drugs and medications don't work. So, for example, men who may have very bad diabetes, who've had radical prostatectomy or surgery on the prostate, they can't get because there's a problem in blood flow and nerve damage. They can't get an erection using tablets, and sometimes they have to use various other devices, such as injections into the penis, or even pellets that you put down a water pipe, and also vacuum devices, which are pumps that you can use as well, which work very well indeed as well. So there's always hope in terms of erectile function, even if tablets don't work. Some men have talked about shockwaves, throwing shockwaves at the penis, a kind of relatively new treatment where you can fire shockwaves at the penis and you can create new blood vessels, according to studies. Again, this is available and sometimes works as well in combination with tablets like Viagra and Cialis. I'm just going to move a couple of slides. But injections, therapies, and creams onto the penis, and also putting pellets down, are still associated with problems. And one of the problems, believe it or not, is with some of these medications is that you can actually get an erection that doesn't go down, surprisingly. And that's a surgical emergency. That's called priapism. Sometimes injections can cause bending of the penis, and sometimes injections can cause pain at the site of the injection. So they're not without problems, but equally they do work very well. And these are some of the types of drugs that we use for men. The commonest one is something called PG1, which is a prostaglandin, which is called Cavaject. Very occasionally, men just don't respond to problems with their erections. And what happens is that overall, you tend to then have to move on to surgical intervention. So you then have to put implants in, and there are different types. And these are rods that replace the muscle of the penis. Remember, we know that the erections are due to dilatation of the muscle tubes of the penis, and then you then have to replace them with these, which are implants. There are two different types. This is a semi-rigid, as we call it, or malleable implant, which means the penis is going to be always erect and you bend the penis down. And the other one is an inflatable device. This is a pump which is put in the scrotum. There's a reservoir which goes in the abdomen, which contains fluid, and you pump up the implant and release the implant and allow the fluid from the two tubes to then deflate, and this replaces the erectile mechanism again. And this is something that we do. So I'm going to finish there, but just to highlight in terms of fertility, because I know that this is about fertility as well. what kind of problems do we see in men, particularly with fertility? Well, one of the issues is sometimes low testosterone, but commonly what I said right at the beginning was that often men, when they're trying to have children with their partners, what happens is that the erection goes down. And when the erection goes down, it's often psychological because you're trying too hard at the time of ovulation, and therefore often it is psychological. Some men, of course, can't ejaculate. They're under too much pressure. And what's quite interesting is sometimes they have difficulty ejaculating. It's delayed. And that's quite important when patients are going for IVF treatments. And sometimes we often ask patients before they go for IVF treatments, how well can you ejaculate? Can you ejaculate? And very often I have been, or patients have been asked to see me, and we've often have to freeze sperm even before they do those treatments. So it's really important to ask about a sexual history when we're talking to patients, even about treatments in terms of erection problems as well, because that also may be important. Now, you also got to remember that, we assume that couples are having sex commonly at the same, at the right time. We also assume that actually they're having sex frequently. And you'll be surprised that you often find couples, they wonder why they're not getting pregnant when they have problems in terms of the fact they're not meeting often, they're traveling, maybe they're too tired to have sex. So it's very important to obviously ask these questions. Thank you very much.
Thank you so much indeed for your thorough presentation. Lots of details, of course, here, but this is something that we want to hear because it should be more out there, I think, as well. So thank you so much for that. And now it will be time
Pleasure.
for all of your questions, of course. So we have some questions ready. If you haven't asked yet, go ahead and type the questions in and we will answer them for you one by one. I mean, of course, Dr. Professor Minhas will answer them for you. And let's start with the very first question that we got, okay? And let me go to this one. So what role does testosterone play in restoring sexual function?
Okay, very good question from Catherine. So it is important. So testosterone is not only important in puberty in men, so it's the kind of causes the pubic hair, the voice to be deeper. So it kind of gives that masculinity, but it's also involved in sexual function. And testosterone actually has an effect on some of the chemicals that are released to actually to cause an erection. So it is very important indeed. Now, interestingly, there are studies which show that the testosterone has got to be pretty low before you get erection problems, and not many people are aware of this. And there's this kind of controversy as to what is the level of testosterone that could cause that. But generally speaking, any male with erectile dysfunction, what we would tend to do would be to measure the testosterone. But testosterone is important on a physical level and a kind of physiological level for erectile function. But it's also important, remember, in terms of your kind of deep voice, body hair, and the kind of that side of things as well.
Excellent. Thank you so much, Catherine, for your very first question and, of course, for your answer to the very first one. Now we will have another question from Tani, a bit of a longer question here. My boyfriend sometimes has normal erection at the beginning, then in the middle loses his erection and needs to stimulate himself, and then again has it till the ejaculation. I know he had problems with thyroid. He also smokes a lot. Do you think this has influence on the erection?
Yeah, I mean, it depends on, a number of things. Okay, so what we've got to remember is in terms of couples that, it is sometimes when you're trying for children, there's a lot of pressure. So you're kind of thinking about that. So psychology is also very important. In terms of losing erection, that's defined as erectile dysfunction. Sometimes thyroid problems can cause erectile dysfunction. Smoking in itself per se can also cause erectile dysfunction. The only issue would be that it depends on how old he is. I mean, the younger age group men, generally speaking, these kind of factors, yes, potentially could cause problems, but as one gets older, they become more influential. So I suspect, depending upon how old your boyfriend is, Tani, it depends on whether or not these factors are going to be largely contributory, basically.
And as you can see, 47, yes, Tani has had it.
He's 47, so
yes.
Sorry, I didn't realise. So from the age of 47, you'd of course look at it and say, well, look, he is getting into, dare I say, the middle age, and and it happens to all of us, but anyway, he's getting into the middle age, and therefore he probably should have an evaluation. Do you remember we talked about that, roughly speaking, 40% of men of 40, 50% of 50 have erectile dysfunction? Now, there are psychological causes, as we've already mentioned, particularly if you're trying to have children, as we mentioned, stress, for example, maybe work problems as well, maybe he's tired, maybe your compatibility in terms of maybe perhaps you want to have intercourse at a different time to him. So there could be many factors that need to be looked at. But the most important thing is also, we talked about those furrow the arteries, risk of cardiovascular disease, high cholesterol, diabetes, all of these things potentially can cause erectile dysfunction. So I would be saying that, look, if it's a continuing problem, he ought to be evaluated by your local general practitioner to see whether or not there is an underlying problem in terms of the blood flow. And there are simple tests that can be done, blood tests, as we've already highlighted, including a testosterone level actually at that age.
Excellent. Thank you once more for that. Next question is up, okay, an interesting one. How to speak to a partner and convince him for sperm donor? We were told that because of his cancer treatment in the past, he will never be fertile.
Well, it's interesting actually, because I think next week, Caroline, we're doing a talk on sperm acquisition, and I think that would fit very well with that, but I can answer that very quickly. Okay, so one of the issues is that, it depends on the treatment, okay, about cancer treatment. And often in this day and age now, and it depends upon, Ella, how old your partner is, but generally speaking, as modern technologies improve, we generally freeze sperm before patients have chemotherapy or surgery. So that's what we tend to do. So, for example, I do a lot with testis cancer. We always freeze sperm before men have surgery, for example, removal of a testicle, or they have chemotherapy treatments. So we normally hope we've done that. The problem is, we know that certain types of cancer can also affect the fertility. It's not just about having the chemotherapy or removal of an organ. It's actually the cancer itself causes. So problems like leukemia, lymphoma can cause that. So it's interesting that they themselves can affect the fertility. And in some men, we sometimes have to do operations before they have treatment if there's no sperm, but actually afterwards as well, we can do operations, can give treatments to actually see if we can find sperm. Often these problems are related to leukemia, lymphoma, chemotherapy in childhood, and we often then do surgery to try and extract it directly from the testicle. So not all men need to necessarily go for sperm donation, interestingly, and actually they should be evaluated by an andrologist or fertility expert to see whether or not it's feasible to actually extract sperm from the testicle before moving on towards donor sperm. And it largely depends upon the type of chemotherapy, the age at which treatment happened, and the therapy that the type of treatment that was actually given.
All right. Again, thank you so much indeed for that explanation. And yes, you are very right. Actually, next week, same time, 8 p.m. UK time on Thursday, we will have another session with Professor Minhas. So, yeah, I can only encourage you to simply sign up for it already. And let's have a look, of course, at the next question from Karen. So great to hear about male fertility. Thank you. My partner's sperm has low morphology, 3%. And are there medication that would help to improve this?
Yeah, Karen, so that's a very good question. And in fact, today I spent today doing a clinic and talking to patients about abnormal forms. And abnormal forms are one of probably the biggest controversies in urology, and in fact in fertility. And the reason is this, okay, is that often what we see in semen analysis is, patients go to a lab. The labs all vary in terms of their interpretation of abnormal forms. Remember, it can be done manually as well as by computers. And what happens is that the preparation is very different, and therefore you don't get uniformity in terms of how the technique is being done. Now, often just to get isolated abnormal forms is unusual, not in a bad way, but rather normally when you see a fertility problem, it often means all the factors are usually affected. Now, there are some conditions where you get low morphology on its own. These can be certain conditions such as globozoospermia, where all the sperm are globular. But it's very unusual in itself just to have isolated what we term teratogyspermia or poor morphology. Now, what you've got to remember is that men are very strange, or humans are very strange, that we can have up to 96% abnormal forms. That's very high. So your partner's got 3% normal forms, which actually is not bad at all. So we tend to now use perhaps a different concept and move away from the concept of using just looking at abnormal forms and looking at something called total motile count, where we look at the sperm in terms of its motility, the number of moving sperm, which might give a better answer in terms of whether or not a couple have fertility potential or are fertile. So the abnormal forms is a very controversial area, and therefore we're beginning to move more and more away from that on its own to predict fertility potential. Perhaps more importantly, you can have a normal semen analysis, of course, and actually still not be able to conceive. And one of the other issues there is that there's something called DNA damage, which also might be important, but we could probably talk about that next time. Are there ways to improve things? Well, obviously, any form of lifestyle modification, losing weight, Mediterranean type diet. But there is some evidence for taking antioxidants. So there are supplements, of course, as well out there. But there are many, many supplements out there with some evidence that some of these supplements might improve, such for example, selenium, zinc, antioxidants of this nature might improve the semen parameters, particularly motility, but also abnormal forms. There's some evidence for that. But again, the evidence remains controversial. But taking these kind of lifestyle modifications, reducing alcohol, reducing smoking, potentially taking antioxidants may help the number of abnormal forms. But it is a very difficult area. You might go to one laboratory and look at the abnormal, and they might report your abnormal forms is very different from another one. So you've got to be a little bit careful about that. I've seen patients who've got those kind of semen parameters who have conceived naturally. They'd sometimes do a semen analysis before couples try and have children, and you kind of almost opens up a can of worms, because in a sense, you've almost got an abnormality already, and you're wondering, why have I got this isolated problem? But often it's about timing, and what we define infertility as is a couple who are non-contraceptive, who are unable to conceive after a year of unprotected intercourse. In other words, that's the time frames. And roughly 75% of couples conceive by 1 year, 95% by 2 years. So we've got to be a bit careful that we don't overdiagnose and overtreat and over-worry patients, actually, by looking at these kind of very small differences.
And wonderful. Once again, thank you so much for answering that thoroughly. And of course, there is a thank you from Karen for you. And there is also a thank you from Tani, from our previous patient. Okay, and this you have mentioned, I think, before, but of course, let's have a look. Catherine has added, is erectile dysfunction a normal part of aging?
Yeah, and I don't know if you remember those slides. I'm sorry they were a bit technical, but as you get older, and you can see that the percentage increase in the risk of erectile dysfunction. Now, it's interesting that it's not just about your furring of your arteries, because obviously as you get older, you get more problems in terms of cardiac disease and therefore furring of the blood supply to the penis. But actually, interestingly, what you also get is this age-dependent change, so that the muscle of the penis changes as well. So in itself, I think you could argue that erectile dysfunction is a normal part of aging. If you look at kind of sexual activity as people get older, the number of times people have sex gets less and less as they get older. Testosterone levels, interestingly, fall after the age of 40. So I think, Catherine, you were asking that question about testosterone before. So therefore, the two would appear to be interlinked, and testosterone does have effects not only on chemicals, but also on the muscle bulk of the penis as well, we think. So it is a normal part of aging, yes.
All right, thank you for the clarification to that one once more, of course. Okay, Ella has another question. Can you please explain TESA procedure?
Yeah, I mean, again, next week I was going to talk in more detail, but again, it's interesting. So I think that the question, so for somebody, for example, who's had chemotherapy, for example, we see many patients who've had chemotherapy treatments who are azoospermic, who don't have sperm in the ejaculate. We sometimes use the TZ procedure, which is testicular exploration and sperm extraction. So in other words, you go into the engine room, which is the testicle, to extract sperm. So there are certain circumstances you do it, and a brief overview would be to say that you generally do it in patients who don't produce sperm and ejaculate, azoospermia. which can either be due to a blockage, which is obstructive, or could be due to a non-obstruction. And these are the different types of scenario you may get. Non-obstruction is usually caused by chemotherapeutic agents. Often, in 70% of cases, is unexplained, but it can be genetic causes. But what you can do in this operation, and what I do is my preference, is I've got a microtesia or microdissection, testicular sperm extraction, which is an operation invented by somebody called Peter Schlegel in New York, and where you do an operation to open the testicle up like a book. Now, interestingly, what you can do in non-obstructive agiospermia is find sperm in 50% by using this technique. But we don't know why you can get it in the testicle, in other words, the engine room, but it doesn't come out in the ejaculate. That's a question we've not been able to answer. But yes, you can do testicular expiration sperm extraction. There are different kind of types. We tend to now think that the microdissection testicular sperm extraction, which is under a microscope, is the best technique for this, partly because it has reduced risk. But there are also other reasons why you might do a testicular sperm extraction. That is, in some men who have got a blockage, where you can't get it with needles, where you can't put it into the sperm tube at the back of the testicle called the epididymis. You might have to go into the engine room to try and extract the sperm from the testicle itself. And then you could use that sperm for ICSI treatment. So you can freeze the sperm and then use that for ICSI.
All right, wonderful. Thank you so much. And I believe now we will have our final question. However, if you have anything else you would like to ask, go ahead and type those in and let's have a look. Okay, this is something that we do receive quite often here as well. So that's drinking alcohol cause erectile dysfunction.
Yes, it does, and I think that there's more and more emergent data. I mean, I think that if you look at kind of studies, there is evidence, and we've done our own studies which we've not actually published, but we found that drinking alcohol was associated with IVF outcomes, for instance. So we don't know the full effects of alcohol on sperm, but certainly within limits is reasonable. I think that to say to somebody, look, don't have a drink at all, we don't know the evidence of this, but equally, patients who are drinkers, and what we did was a kind of brief study, we found that if you were drinking alcohol, you had worsened outcomes, interestingly, from IVF treatments. But that was a very small study, which we've not published and be treated with caution. But there are other studies in the literature reporting the effects of alcohol. So I think within, if you look at some studies, they talk about 5 to 6 units of alcohol less would be the optimum. I think if you're trying, then, and you're really motivated, of course, it's a bit of a catch-22 because you're stressed, but if you're motivated, it's probably better not to drink alcohol.
Oh, of course. Thank you so much for yet another question, of course, and for your help with that. And Karen has added one more question, okay? When looking at the total motile sperm, would 76% be a healthy number?
Yeah, so 76% is a normal healthy number. It should be 40% and above, looking at the motile sperms. In other words, how many sperm are moving in a sample. People describe it down to progressive motility as well. So 32% sperm are progressive, i.e. going from A to B. But there is a concept, as I already mentioned, about the total motile count, which is slightly different from motility as a percent. That's the total number of sperm within the sample that are moving, which you can work out, actually, which takes out, sorry, a whole issue of abnormal forms. Excuse me, I just have to have a drink.
Of course. Thank you so much indeed. And let me have a look, okay, if we have any more questions. If not, we will be finishing for tonight. But as I've mentioned already, you know that you can join us next week on Thursday, and we will have another Q&A session. So, of course, you can... sorry, Karen has added something. Sorry, it says total motility, 76%.
So the total motility of 76% would indicate that the total amount of moving sperm in the sample is 76%. That's what that means to me. So that would be a healthy number, yes.
All right. Thank you for the clarification once more again here. Okay, and thank you so much. I do not see any more questions, so we will be finishing. There is thank you already for answering all the questions from Catherine as well. And of course, before I let you go, Dr. Minhas, anything else you would like to add?
No, I'm just really impressed with the questions, really in depth and probing questions, especially from Catherine. So, but yeah, it's very interesting. Hopefully that was of use to you.
Definitely useful. So thank you so much indeed, everyone, for your questions, because yeah, this is definitely an interesting session, and I'm very, very happy that we are bringing those topics to you, because I definitely feel that there is a need to discuss it more and more often. So thank you so much, Dr. Minhas, for joining us tonight once more. As you can see, more thank yous are coming up your way, of
It's a
course.
pleasure.
So
It's a
just
great
wanted
pleasure.
you to see that. And remember, it has been recorded, so if you wish to just simply have a look at the webinar once more, you can do it. Just go to our website, My IVF Answers, and you will be able to find this there, but also on our YouTube channel. And if you go to our Facebook or Instagram, you know that there are plenty more events coming up. Also, tomorrow we will be here at 8 p.m. UK time, and we do have another topic to discuss on male reproduction, as I mentioned. So I do hope to see you there tomorrow. And once again, thank you so much, everyone. Have a lovely evening, Dr. Minhas. I am very happy that we will be having another webinar next week. So see you on Thursday then. Okay, take care.
Thank you. Bye.
Bye.